wanna settle that scar, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winter leaving. It's redemption season. Long live the young and high. Cheers to a brand new start. We're revived and breathing to live a life of freedom. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, and life is a race we run, so run till the race is won. Don't you ever give up, no, no, never give up. Life is a race we run, so run till the race is won. Don't you ever give up, we will never give up. To everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa.
Good evening, everybody. Good night, everybody. It's my pleasure to introduce you Professor Naduvil. He's currently working at Cleveland Clinic in the States. He is a child neurologist and epilepsy fellow and a consultant epileptologist from Cleveland Clinic. His main interests are localization of seizures and epilepsy surgery. He has published around 60 papers and book chapters related to epilepsy, and most of his notable contributions are related to hemispherectomy in children in terms of seizure and functional outcomes, and hemispherectomies in adults. Pleasure to have you here.
Thank you, Sebastian, for that kind introduction. Can you hear me okay?
Yes.
Okay, very good. I thank the organizers of the ILAE Young Epilepsy section for inviting me to talk at this amazing educational program. I chose a topic that I love to talk about, a topic that I talk with my colleagues and trainees. I give a variation of this talk to the fellows at the Cleveland Clinic during our epilepsy EG course. Drug-to-drug interaction is one of the most difficult subjects to master in epilepsy practice. It is rather a difficult task to memorize all the drug interactions, unless one has a logical approach to the drug interactions. I plan to review this topic from various different angles. I would talk about various enzymes involved in the metabolism of the drugs and the substrates for individual enzymes, and talk about enzyme inducers, talk about enzyme inhibitors, what are the drugs affected drugs, offending drugs, and whatnot. Hoping that such a mesh of knowledge will help you to remember these interactions better. And in the next 45 minutes, I would highlight some of the pharmacokinetic drug interactions between different anti-seizure medications. I will use some clinical scenarios to showcase these certain principles. I would like it to be interactive, but I understand that there are limitations of how interactive it could be on a virtual platform like this. I have a few questions that is integrated in this talk. You can type as a multiple choice kind of a response, so you can type your answers in your YouTube chat box. The moderator will give me some of the more prevalent answers. It would be fun to have that. And we will also review drug interaction between anti-seizure medicines and non-anti-seizure medicines, in particular birth control medications, and also medication used for other indications. And in general, we know that the drug interactions are relatively less frequent with the newer anti-seizure medications, but there are some unique inhibitory mechanism drug interactions with the newer ASMs as well. And I'll briefly touch upon some interactions of ketogenic diet and some anti-seizure medication levels. And I do not intend to cover too much about the pharmacodynamic interactions, but I have a couple of slides about that. And I probably will not go into the details of absorption-related interactions. Certain medications given by mouth can interact with certain antiepileptic. They are relatively uncommon, less frequent, so I'm not going into those details here. So, in effect, any drug interaction leads to two different things. Number one, either it increases the anti-seizure medication, which can lead to toxicity symptoms, or it can reduce the anti-seizure medication that puts the patient at risk for increase in seizures. And this could be a result of a variety of different mechanisms. Usually the mechanism that affect the clearance of the medication, either by hepatic clearance or renal clearance. And occasionally you could have a drug interaction that leads to an increase in level of the free drug levels due to a displacement from the protein binding sites. And lastly, you could have some absorptions may be affected that may reduce the drug levels. So first, we will talk about the various enzyme systems that is involved in the metabolism of antiepileptic drugs. Now, there are two broad categories. There's a hepatic metabolism as well as the renal excretion. And in the hepatic metabolism, we often talk about cytochrome oxidase pathway-related enzymes. And there are multiple different CYP enzymes, but the three enzymes that is relevant to anti-seizure medications are CYP 2C9, 2C19, and 3A4. And the common substrates that is metabolized by these pathways are for 2C19 is phenytoin, lacosamide, and one of the clobazam metabolite. And 2C9 is many of the older generation medications, including phenytoin, phenobarbital, and valproate. And 3A4 carbamazepine is the most common anti-seizure medication that is metabolized predominantly by this pathway. So remembering some of these things can help you to understand what kind of drug interaction is going to happen with a medicine that may induce these enzymes or inhibit these enzymes. And then you have this UDP glycosyl transferase pathway metabolism, where you have glucuronidation of the lamotrigine. Lamotrigine is the main metabolic pathway is through this UGT pathway. Valproate also has got a minor pathway for metabolism through this pathway, and also lorazepam. Epoxide hydrolase is important for metabolism of carbamazepine epoxide. Carbamazepine epoxide is a toxic metabolite that is converted from carbamazepine to carbamazepine epoxide that needs to be detoxified by this enzyme epoxide hydrolase. So these are the major enzymatic pathways that is involved in drug interaction that you need to remember. And there are many medications which are predominantly eliminated by renal mechanism, which includes the list of medicines I have given here. Some of them, for example, gabapentin, pregabalin, more than 90% are renally eliminated. Others have a combination of renal and other mechanisms. So let's talk about case one. The cases I have here are from my personal practice. I've tried to simplify certain things for the purposes of driving a straightforward message here. So this child I took care of maybe 5 or 6 years ago. Is a 6-year-old boy with Mowat-Wilson syndrome. He had developmental delay, epilepsy. He was seizure-free for 2 years on sodium valproate. And he presents to the ICU with a breakthrough seizure that went on to become status epilepticus. He was treated in the emergency room, seizures persisted, he required treatment with phenytoin, phenobarbital, and subsequently a refractory status. He ended up in the ICU with pentobarbital infusion. He was also on topiramate during the hospital stay. The issue was about the valproate level in this patient. This was the day 1 of admission. That was his home dose, and he was 44 milligram per kilogram. The level was 106. For those of you who may not be familiar, the valproate level, the range is from 50 to 100. In patients who are difficult to control, we often get closer to 90 to 100 level. This is about the total valproate level. If we look at day 4, the levels dropped. We had to increase the dose. Levels further dropped. We had to further increase the dose. So you can see day 14, the levels kept dropping despite we trying to increase the dose. As you can see, there is a humongous amount of valproate being given. One of the things our team was thinking was he was seizure-free on valproate, so we tried to save the valproate, keep the valproate. We given IV, given every 6-hourly doses, but still the levels were plummeting down. So the first question is, all of the following cause lower levels of valproate except number 1, enzymatic induction from phenytoin. Number 2, enzymatic induction from phenobarbital. Number 3, enzymatic induction from pentobarbital. Number 4, co-administration of topiramate. Let me see if let me pause for a few seconds to see if you guys can give me some answers. Sebastian, I'll wait for 10-15 seconds maybe. You
Yes,
tell me when to proceed.
Okay, let's wait.
So the one thing that is particularly important is at admission, very low levels, doses, almost 4 times the dose we are giving right now. At 3 weeks later, the levels are only 50% of the original levels.
So we have had number one as our first
Okay.
favorite response.
Okay, all of the following cause lower levels of valproate except, I think it's an except question here. Sometimes it can be confusing for you. Let's talk about the metabolism of valproate. Valproate is metabolized by multiple different mechanisms, including glucuronidation, beta oxidation due to mitochondrial pathways, and cytochrome oxidase pathway as well. And the medication that induce the cytochrome oxidase pathways as well as the UGT pathway are the first generation medication like phenytoin, phenobarbital, primidone, and carbamazepine. They are kind of a non-selective inducers of multiple enzymes. Okay. So this patient was on phenytoin, phenobarbital, pentobarbital. All those things produces marked induction of these enzymes that metabolize the valproate. So the answer for that question was all these things can lower the levels of valproate except the administration of topiramate. Topiramate do not have any direct interaction with the valproate metabolism. Okay. So all these medicines, phenytoin, phenobar, pentobarbital, have marked induction of the enzymes that metabolize the valproate, resulting in lower levels of the sodium valproate. So if you look at the enzyme inducers, we know that the first generation anti-epileptic drugs, they are very prominent enzyme inducers. As I listed here, all four of them induces multiple different types of the enzyme pathways. So that can lead to increased metabolism of many different medications. We often talk about carbamazepine induces its own metabolism. It's called auto-induction because carbamazepine is an inducer of 3A4, for which carbamazepine is a substrate. That's why when you start people on carbamazepine, you often start with a lower dose. Even with a lower dose, they may have a good levels. 3 weeks later, if you continue the same dose, there is an auto-induction happens and the levels will be lower 3 weeks later. That's why we kind of slowly increase the dose of carbamazepine. In terms of other CYP3A4 inducers, some of the relatively later used medications like salbamate, oxcarbazepine, topiramate, rufinamide, perampanel, all of them have a rather narrow range of enzyme induction that happens with CYP3A4. And this list is important because this is the same list that will again come later because of its interaction with the birth control pills, because birth control pills use the CYP3A4 pathway. Let's see here. I'm coming back to the case one. There is no question here, so you don't have to worry about the audience response here. So this is the same patient we talked about, the patient who was in the ICU for several days, probably weeks. We finally got to a level of closer to 90 to 100 of valproate level with a daily dose of 2800 milligram, which is about 140 milligram per kilogram per day. So let's see what happened. This patient went to from the ICU to the floor to the rehab, and subsequently, I'll show you the levels here. This is 3000 milligram per day. The levels were ranging from 60 to 85. And then suddenly levels started climbing up. We started reducing the dose of the medicine. The levels kept being higher. We had to reduce further. We had to reduce further. So we started with 3000. Now we back to 1200. And the level is now steadily in the therapeutic range. Okay, so what happened here? So it is important to know that something happened around this time that required lower dose of valproate. That's because the patient's pentobarbital was discontinued. Phenobarbital was also discontinued. These two are a potent enzyme inducers. Whenever you have a high dose phenobarbital, there is a marked enzyme induction. Invariably, other medicines are affected. So even if you stop these medicines around this time, it took around 2 to 3 weeks for the levels to climb up. That's because the enzyme de-induction may be delayed. So when you start an enzyme inducer, it doesn't produce enzyme induction right away. It takes around 1 to 3 weeks for the enzyme induction to kick in. So if you are not anticipating, you may completely miss it. The same thing happens for de-induction. You stop a medicine, the effects of the enzyme induction is going to take some time to go away. So you need to anticipate this thing. So if you're going to stop phenobarbital and you knew that you were giving high doses of valproate, you should check the level a week, 2 weeks later, and see proactively reduce the dose of this medicine. So that's important here. So in terms of the newer anti-seizure medications, as I mentioned earlier, felbamate, CYP3A4, oxcarbazepine, all these things induce CYP3A4. Felbamate, oxcarbazepine, topiramate, perampanel, rufinamide, and vigabatrin induces a different enzyme, CYP2C19, which is an important enzyme that metabolizes phenytoin. So whenever you see CYP2C19, we often think about phenytoin levels being affected here. Moving on to the second case. So this is again a multiple choice response. Let's see what the audience say here. Maybe I'll give the responses here so that they can read it. This is a 21-year-old young woman with juvenile myoclonic epilepsy. She is on lamotrigine 200 milligram twice daily, is admitted with recurrent generalized tonic-clonic seizures. And the lamotrigine level at admission to the hospital was 13.2 microgram per ml. The reference range is between 2 to 14 in our lab. After extensive discussion, because of recurrent GDCs, you elect to start valproate. I know there are issues related to valproate in young women, but this patient probably failed other medications before. That's the reason we are talking about it. So she received a loading dose of 1 gram of valproate. What adjustment to the lamotrigine dose will you make? The choices are, number 1, reduce lamotrigine dose by 10% 2 weeks later. Reduce lamotrigine dose by 10% from next dose. Number 3, reduce lamotrigine dose by 50% 2 weeks later. Number 4, reduce lamotrigine dose by 50% from the next dose. Okay,
let's wait at least 1 minute so people can answer because we had a delay on the streaming.
Okay, that's fine. So this is a common problem. Patients who are on lamotrigine are the ones who end up receiving valproate, because they both have a same spectrum of broad spectrum anti-epileptic drugs, and they frequently used in generalized epilepsy. And even if you remove this gender of this patient, we may be talking about using these medicines for juvenile myoclonic epilepsy.
So until now, we have had 2 fours and 1 person to the first one.
Okay, so 2 people answered. So it looks like more people will choose number 4 as the right option. That's the right option here. Let's talk about lamotrigine and valproate interaction here. Lamotrigine uses this UGT pathway, and valproate is an inhibitor of this enzyme that leads to increase in the lamotrigine. So the lamotrigine clearance is decreased by 50%. And this inhibition may occur within hours. Okay, there is a study that reports that the inhibition of valproate-related inhibition and increase in lamotrigine can happen within an hour. That's why you need to reduce the lamotrigine dose by 50% from the next dose. Okay. It will also depend upon what was the original level to begin with. If the patient is on a very low level, if you want to still keep on lamotrigine, we may keep a slightly higher dose. But this patient is already on a higher dose here, upper range of normal. If we do not make any changes within a day, this is going to double, probably close to 20 or 25. So it is very important to reduce from the next dose itself. So if you're giving a sufficient dose of valproate, you reduce the lamotrigine by 50% by the next dose. So enzyme inhibition is a rather interesting mechanism, and there are several different scenarios in which enzyme inhibition produces drug toxicity. Felbamate is an it has got a unique drug interaction. It induces certain enzymes, it inhibits certain enzymes. Felbamate increases phenytoin because of the inhibition of 2C19. Felbamate increases carbamazepine epoxide by inhibiting the epoxide hydrolase. And valproate also increases rufinamide, but is less dramatic than lamotrigine. Valproate increases carbamazepine epoxide again by inhibiting epoxide hydrolase. And as we often talk about, the newer antiepileptic medications have much less chance for interactions, but there is a list of newer anti-seizure medication with enzyme inhibiting properties. Number one is cannabidiol. Usually when we start cannabidiol, their patients are already on either valproate or clobazam. And they often develop significant clobazam-related side effect because of the inhibition of its CYP2C19 that increases a metabolite of clobazam. So if you just check the level of clobazam, that may not be elevated, but the metabolite of the clobazam, which is N-desmethylclobazam, is markedly elevated when you use with cannabidiol because of the inhibitory mechanisms. Brivaracetam is another newer anti-seizure medication which inhibits epoxide hydrolase, and this is important for metabolism of the carbamazepine epoxide, so it can produce toxicity. Cenobamate, which is now in the market with a unique mechanism of action. Again, you may have heard about its interaction with phenytoin and phenobarbital because it inhibits CYP2C19, thereby increasing the phenytoin and phenobarbital levels. So you may have to proactively reduce these doses, especially if they are already on a good dose of these medicines. Clobazam, again, it does not have an interaction with an anti-seizure medicines, but one of the dextromethorphan is metabolized through this enzyme, so it can produce some toxicity related to that. Eslicarbazepine is also an inhibitor of CYP2C19. So the three enzymes you need to remember in anti-seizure medicine metabolism is CYP3A4, CYP2C19, and CYP2C9. Those are the three enzymes that comes repeatedly. So these are the enzyme inhibitors. Valproate is an inhibitor in the UGT pathway here. In the 2C19, we talked about cannabidiol, again, cenobamate, felbamate. Cenobamate and felbamate kind of sound similar. The kind of interactions are also similar, easy to remember. And 2C9 and 2C19 are inhibited by valproate. Valproate is an inhibitor of multiple enzymes. And stiripentol is another one. Usually the enzyme inhibitions are rather a narrow range of enzymes, but exception is probably stiripentol. It inhibits all the enzymes that is frequently important in drug metabolism, 3A4, 2C19, and 2C9. That's why stiripentol often lead to a host of drug interactions, especially with an older generation medications here. And the medicines that inhibit epoxide hydrolase or valproate, felbamate, and brivaracetam, all these things can produce carbamazepine-related toxicity because of carbamazepine epoxide increase. So again, I want you to recall the substrates we talked about earlier. And these are the substrates we're talking about. These are the enzymes important for the metabolism of these medicines here, listed here. Your lamotrigine, valproate, lorazepam for UGT pathway, carbamazepine epoxide for epoxide hydrolase, and some of the renal enzymes here. So in summary, the enzyme induces the metabolism enzyme and then reduce the drug levels, and the inhibitors increase the drug levels, but some interactions are more complex. And the best example is carbamazepine. We'll see the carbamazepine metabolism here. You can see carbamazepine is metabolized to carbamazepine epoxide by the enzyme CYP3A4, and the epoxide is detoxified by epoxide hydrolase to this compound. This is non-toxic. And many of the first generation anti-seizure medicines and felbamate induces CYP3A4, which means they will reduce the carbamazepine level. Okay. And other medicines inhibit CYP3A4, which includes grapefruit juice. That's one thing we often say when patients are on carbamazepine, not to drink High consumptions of grapefruit juice can lead to toxicity of carbamazepine because it inhibits the 3YP, CYP3A4. And epoxide hydrolase is inhibited by felbamate, valproate, and brivaracetam. So what happens is if you give felbamate for a patient or brivaracetam for a patient on carbamazepine, the patient develops toxicity symptoms. But if you check only the carbamazepine levels, they may be completely normal within range. Only unless you test the carbamazepine epoxide level, you may completely miss what is the reason for this. So it is important to anticipate these drug interactions when you add these medications. And to make it even more complex, look at felbamate. What felbamate does at two levels here. Felbamate induces CYP3A4 and inhibits epoxide hydrolase. The combination is even more deadly. Carbamazepine is converted into a toxic metabolite quickly, and the metabolite is not eliminated quickly, so it can produce significant toxicity symptoms. In fact, inhibition, the mechanisms are often more dramatic. So this is just to compare and contrast enzyme inhibition and enzyme induction. Enzyme inhibition often affects the drug levels immediately. We talked about if you use valproate, you have to change the dose of lamotrigine within an hour. Whereas enzyme induction, as I said, it takes 1 to 3 weeks. So you may go unnoticed until the patient comes back 2 weeks later with seizures because of reduced levels. And enzyme inhibition is often more dramatic and clinically significant interaction because they come with toxicity. When they come with seizures because of lower medicines, seizure is seizure. The patient with epilepsy are expected to have seizures. So it's not as dramatic, but a toxicity-related side effects is often very dramatic. And whereas the enzyme induction, unless the seizures occur, they may go unnoticed sometimes. Enzyme inhibition is often selective, very narrow spectrum of 1 or 2 enzymes are involved, except probably stiripentol. Stiripentol has a host of enzyme that is inhibited. Enzyme induction is often broad, especially with the first generation anti-seizure medicines. But in newer ASMs, there may be enzyme induction could be more selective. And enzyme inhibition, anticipate, forewarn, and be proactive in many situations. You have to reduce the medicine if you're expecting an enzyme inhibition. Otherwise, patient may have toxicity symptoms. Whereas an enzyme induction, you probably can have time, watch, check the levels, and do it. But you need to anticipate these things. Again, as I said, after stopping the enzyme inducer, it takes about 1 to 3 weeks for the induction to subside. So that's the time you will be anticipating a drug toxicity. So it's important. Enzyme induction also can lead to drug toxicity when you are stopping the inducer. You need to anticipate. We'll move on to case number 3 here. This was a patient we took care of probably 5 years ago. He's a 16-year-old young man with refractory epilepsy due to sodium channel ATA mutation. As some of you would know, there are certain sodium channel diseases where which sodium channel blockers are the preferred treatment. SCN8A is one of the genetic conditions where you treat with sodium channel blockers. Whereas SCN1A, you want to avoid sodium channel blockers. So serial anti-seizure medication levels were performed due to poor seizure control and toxicity features. So I'm going to basically list, this is the dose of phenytoin in the first column and dose of other medication in the second column. And we have a level of phenytoin in the third column and a free phenytoin in the fourth column. So this patient was on a 300 milligram per day of phenytoin. Patient was also on valproate at that time. That's the total level 7.4, free level 1.4. And for those of you who may not be familiar, total phenytoin is 10 to 20 is the range. Usually 10% of the total dose is the free dose, free levels, okay? So we are reducing so we keep monitoring this patient and given additionally topiramate here. You see the levels here, 10.5, 12.5. The levels keep climbing, so and also the free levels are high, okay, 2.4. The free level, anything more than 2 often may lead to toxicity symptoms. We are continuing to reduce the dose of phenytoin, and you can see the free phenytoin level continues to be on the higher side. So the question here is the reason for the high free phenytoin level is, the options are, number one, at high levels of total phenytoin, the free levels disproportionately increase. Okay. Number two, valproate protein binding displacing the phenytoin, leading to high free phenytoin. Number three, inhibition of CYP2C9 by valproate. Number four, free levels tend to be high in SCN8A mutation. So these are the options. Let me pause for a few seconds. I'll wait for Sebastian to give me a go. So we are focusing mainly on the high free phenytoin levels. This case is a little bit more complex. There is one more interaction here. We will talk about it after we discuss this aspect of the case. This patient stayed in the hospital for several weeks because this happened 6 years ago. At that time, we were not, the knowledge about SCN8A and use of phenytoin as a preferred drug was not available. Every time we tried to take up the phenytoin, he went into a status epilepticus, very prolonged seizure. So ultimately, we sent him home on phenytoin. Subsequently, it became clear that SCN8A mutations, phenytoin is an effective drug in these patients.
Maybe we can wait a few seconds more. We have had various answers between the most popular is 2. We have one person that answered 2 and 3, and one person answered 3 and 1.
That's good. That's good. I think varied answer means that it's important to learn this topic. That's what it means. So number 2 is the right answer. I'll come to it. Protein binding is not a common mechanism of drug interaction in epilepsy practice, but there are some unique scenarios it can happen. Some anti-seizure medicines are more protein bound than the other. The medicines that have a high protein binding capacity are the phenytoin, valproate. Those are the 2 important ones for drug interactions. Also diazepam, clorazepate, lorazepam, diagabin, and perampanel. As you know, the bound drugs are not active because they do not cross the blood-brain barrier. Only the free drugs cross the blood-brain barrier. And if there are 2 highly protein-bound drugs are there, it sets the stage for displacement from the protein binding sites that leads to increase in free fraction. And this protein binding is clinically relevant only if the protein binding is high, only if it is more than 90. If it is 40%, 60%, 70%, it generally does not have any impact on the drug interactions. Only if the protein binding is more than 90%, it could have drug interaction. For in epilepsy practice, the only clinically relevant protein binding related drug interaction is between phenytoin and valproate. And usually the issues related to this are rather transient. If I go back to the previous stage here, and the question here, for 21 of the total level, we expect the free level to be around 2, maybe 1.8 to 2.4. It is almost double the levels here. And double these levels, these are free levels that can produce toxicity. But if you just check the total levels alone, you may not realize that this patient is toxic from phenytoin. So that's the importance of recognizing that there is a possibility for a protein binding drug interaction, and you have to check the free level in that scenario. And usually the toxicities are rather transient because once you have more free drug available for metabolism, it will be cleared more efficiently. So after 1 or 2 weeks, this protein binding thing, it kind of dissipates into that, even if you don't make any dose adjustments. So it doesn't usually have no long-term consequences. But the importance is recognizing the interaction and checking the free level to diagnose this. And there are other factors that also influence the protein binding interaction. There is something called the hepatic extraction ratio, which is related to the first pass metabolism. So whether you give by IV versus oral or some of the factors. So those are the other factors that makes the other medications less prone for such interactions, like perampanel and tiagab in the past. They were not prone for the protein binding related drug interactions because of other factors. Valproate protein binding can be a little bit unique because the binding sites appear to be saturable at therapeutic concentrations. So the levels on the upper end of the therapeutic, the protein binding sites are saturated and the free fraction disproportionately increase. So that's important there. So if you have if you're in the upper end of the levels for the valproate, you check the free levels because they are often higher. It doesn't usually happen with phenytoin, and that is one of the options that is given. So that is applicable for valproate. So the free levels disproportionately increase in the upper end. So you need to check the free levels. So in this same scenario, if you look at the, in addition to the protein binding drug interaction, there is one more drug interaction here. Despite decreasing the phenytoin level, the phenytoin total level kept increasing. So that you cannot account by protein binding drug interactions. So there probably a metabolism of the phenytoin is impaired. We know that the valproate inhibits 2C9 and 2C19, and also topiramate also inhibits one of the phenytoin metabolizing enzymes, is 2C19. So possibly this combination was also working against this. So there is an increase in total level disproportionate to the dose we are giving. So despite reducing the dose, the total level kept increasing because of enzyme inhibition. So a little bit more complex than what it appears here. Okay, so that's the maybe topiramate and the valproate. One other thing to be aware of is the alteration of the half-life medicines and its impact on dosing regimens when you use enzyme inducers and enzyme inhibitors. For example, lamotrigine half-life is approximately 24 hours. If you don't use with any inducers, enzyme inhibitors, but it could be 48 hours if you're using with valproate. It could be shorter if you're using with enzyme inducers. So it is important to remember that, so that when you're dosing this medicine, the patient with enzyme inducers and lamotrigine, you have to give a twice daily dose. With valproate, you can easily give a once daily dose. This is one of the favorite cartoons. This is from a publication by Veruca and Sakara here in epileptic disorders. I recommend you check this cartoon here if you're not familiar with this. I'll try to highlight certain things here. So this is anti-seizure medications. This is pre-existing drugs in the top column here, in the columns here. And these are the drugs that is added here in the rows here. As you can see, the red one means marked increase in the serum concentration. So if the pre-existing medicine, you add this marked increase in serum concentration. Blue means marked decrease in serum concentration. So obviously the red ones are much more dramatic. It's probably when there is an increase in concentration, what does it mean? There is possibly an inhibitory mechanism that is playing, okay? When there is a decrease in concentration, it means there's an enzyme induction mechanism playing here. So if you look at the red ones here, felbamate, you can see that there's probably an increase in phenobarbital, phenytoin, and valproate because of the inhibitory mechanisms. Same thing with valproate. See this phenobarbital, lamotrigine increase with valproate. So we give you one more red ones here, red line here, stiripentol. Again, because of the inhibitory mechanism, it increases clobazam, carbamazepine, phenytoin, tramadol. So it's a pretty good cartoon. It's cool. I checked several different interactions. They look pretty accurate. As you can see, there is a lot of footnotes in this table. So if you have 47 footnotes, that means that table has to be really, really good. Okay. So I recommend you to take a look at this article. That's the PubMed ID here, and it's a beautiful article. Going to the next section, scenario number 4. This is not a question here, so there is no audience response expected here. It's an 18-year-old woman with juvenile myoclonic epilepsy on lamotrigine 200 milligram twice daily, seeks advice on birth control. What would you recommend? Okay. So this would be a common scenarios, people who are taking care of young women. So that brings the topic of drug interactions and birth control pills between anti-seizure medications and birth control pills. And the common mechanism of interaction is again by enzyme induction, because some of these anti-seizure medicines increase the clearance of the birth control pills. It increases the clearance of both estrogen and progesterone often, because both of the steroids are metabolized by the CYP3A4 enzyme group. So as we talked about, all the enzyme inducers will often lead to this reduction. And there is another mechanism. There is sex hormone binding. Globulin could be increased by certain drugs, especially with the older generation anti-seizure medications. So these are the list of hepatic enzyme-inducing drugs from one of these reference here: carbamazepine, esclarabazepine, oxcarbazepine, perampanel in higher doses, topiramate in higher doses, phenobarbital, phenytoin, primidone, rufinamide. These are non-enzyme inducing. Some of them alter the levels of the birth control pill metabolites, but it does not inhibit the ovulation, so it's safer to use this here. The birth control options for patients with enzyme inducers, you could try with a higher dose of estrogen. If you try, going to depend upon the steroid or birth control pill, often is encouraged to have at least 2 methods together. Depo-progesterone is often used. Intrauterine devices with hormonal coated, they have a local mechanism, so they are not affected by the enzyme inducers. Of course, barrier methods always use double methods, especially with when you are using medication with a high risk for teratogenesis. So again, this is the list of table we talked about. Newer anti-seizure medicines. Look at this, all of them have the CYP3A4 enzyme induction: rufinamide, perampanel, topiramate, oxcarbazepine, felbamate. All those things can interfere with birth control pills and decrease its effectiveness. So with regard to lamotrigine and birth control pill, probably lamotrigine doesn't have a major impact on the birth control pill, so they can use anything, but the interaction is different compared to other anti-seizure medicines, because birth control pills affect the lamotrigine levels. Because the estrogen in the birth control pill induces UGT enzyme and it increases the lamotrigine metabolism. Okay. So it decreases the levels of lamotrigine. Sometimes this can lead to some interesting drug interactions. Sometimes a person may be taking 3 weeks of hormonal containing pill and 1 week of placebo to have menstrual bleeding. What happens is during the weeks the patient is taking the hormone, there will be a reduction in the lamotrigine levels, and with a rebound increase during the period the person is taking the placebo. So it can lead to some different combinations. Again, for the same reason, during pregnancy, there is a steep decrease in the lamotrigine levels in many patients because of the estrogen effect on the UGT pathway. Lamotrigine high doses can decrease the levels of the levonorgestrel, has been known, but it does not suppress the ovulation, so it does not affect the efficacy of the birth control medications here. Case number 5, I believe I have an audience response is required here. So this is a 50-year-old gentleman who is diagnosed with focal epilepsy. He's on treatment with carbamazepine for the past year and has been seizure-free. He presents to the emergency room with acute onset unsteadiness of gait, slurred speech over the preceding 24 hours. An examination reveals unsteadiness of gait, gait ataxia, arm dysmetria, and nystagmus. And on further history taking, it was found that his PCP had prescribed an antibiotic 2 days earlier for sore throat. The most likely antibiotic that caused these symptoms are. Okay, we are talking about carbamazepine, unsteadiness of gait, slurred speech, probably toxicity. And so the options are erythromycin, sulfonamide, amoxicillin, cephalexin, Bactrim. I will wait for some audio responses. Sebastian, you are muted. You need to let me know when you're. This is the real story that happened when I was in training. I was on call. a patient called me with slurred speech, and this person was on carbamazepine. He had some sore throat, and he had been started on an antibiotic. He was allergic to penicillin, so they gave some alternate medication, and he was unsteady, slurred speech. I made the diagnosis on the phone and asked him to go to the emergency room and get the levels checked, and that was the case here. Any responses yet?
No, let's wait, because this slide has just popped up. Yes, most of our viewers are answering A, erythromycin.
Okay. I think most of them, all of them, probably getting it right. Erythromycin is the right answer. Erythromycin is a CYP3A4 inhibitor. We talked about this, the enzyme that metabolizes carbamazepine. CYP3A4 is a very important enzyme. It's according to one reference that is listed down there, it is involved in metabolism of 50% of marketed drugs. Can you believe that? I never knew that. And in fact, I believe that in medical school, there should be a chapter for CYP3A4 if this is the case in pharmacology. But I don't recall that being emphasized during my training, at least. So in terms of the anti-seizure medicine, the CYP3A4 substrates are carbamazepine, felbamate, rufinamide, lacosamide, perampanel, zonisamide. Carbamazepine is the most affected because it's primarily metabolized by this pathway. In terms of the inhibitors of CYP3A4, there are several different medicines, including macrolide antibiotics, clarithromycin, erythromycin. Azithromycin is safe, okay? Anti-HIV agents as listed here. Antidepressants, some of them have interactions. Calcium channel blockers. Several herbal and dietary components, supplements also can produce this inhibition. So that's another thing too. We talked about grapefruit juice. Among the anti-seizure medicines, the one thing that inhibits the CYP3A4 is tiripentol. That's the only thing, to my knowledge, that inhibits that. And of course, there are many enzymes that induces CYP3A4 as well. That brings to a list of other medicines used for other indications. Okay, this is a long list. This is particularly important for people who are an adult epilepsy practice. They may have other conditions. I have highlighted some of the things here. Digoxin, warfarin, oral anticoagulants. If you're going to use enzyme inducers, they markedly decrease the warfarin levels. Again, you need to also remember that if you're going to stop the enzyme inducer in a patient who is on a stable dose of warfarin, if you are not proactively checking and adjusting the warfarin dose with your help of the physician, there is a risk for bleeding. So it's important to know that not only in that, when you stop medicine, what happens? That's another thing you need to pay attention to. Several anti-neoplastic drugs are prone for enzyme induction-related decreasing. So basically, all these medicines could be reduced because of the enzyme inducers. These are the 4 top enzyme inducers. Tacrolimus, we have used it in Rasmussen encephalitis. We had a patient, we were not able to get a good level of tacrolimus because of interaction with the phenytoin and phenobarbital in that patient. So it is good to have a reference. And of course, whenever you use enzyme inducer, you always think about what else is going on with the patient and find out. And these are the medicines that increases these levels, the anti-seizure medicines here. And you can see on the left-hand side, the first column, we have anti-seizure medicines. All these medicines can increase the levels. Examples, we talked about erythromycin, clarithromycin, sertraline can increase lamotrigine level. All these things are presumably due to enzyme inhibition mechanism. Valproic acid could be increased by these medications here. There is one more to this list, which is not by enzyme inhibition, I believe, is interaction between valproate and carbapenem antibiotics. If a patient is on sodium valproate and if is administered carbapenem, so imipenem, meropenem, or trapenem, all these things can lead to a marked decrease in the valproate levels. And the mechanism is poorly understood, and it is said that the dosage adjustment, if you try to increase the dose of valproate, just like the case I showed in the first time, the dose adjustments often does not work. It's kind of actively eliminated from the system. Usually the levels rebound 1 week after the stopping the payments. Okay, so that's another thing in the ICU practice. Patient is in the ICU using valproate and carbapenem. You need to be aware of this. In fact, carbapenem group of antibiotics has been used to treat, has been proposed to treat valproate toxicity. You know, if a patient is on a level of 300 due to valproate consumption, you can give carbapenem antibiotics to eliminate them. Valproate, I don't believe it is easily dialysable. So when you're starting enzyme inducers, it's very important to check other medications for interaction, especially if they're in birth control pills, oral anticoagulants, immunosuppressants, antiviral drugs, antiarrhythmic drugs, a lot of different medicines. And it's, as a principle, it's a good idea to avoid enzyme inducers whenever possible if the patients are taking the above medications. Okay. And again, when you're stopping enzyme inducer, be aware of it, and patients may be on other medicines that may be affected again. Other interactions, diet, modified Atkins diet or ketogenic diet. I have seen in practice that when I start on ketogenic diet, certain medication levels kind of go down. And I was happy to see a publication that came a year ago on 63 adult patients on modified Atkins diet. They found that there was a significant reduction of carbamazepine, clobazam, and valproate when they are taken with the modified Atkins diet, and a mild reduction in lacosamide, lamotrigine, and topiramate. And some of these medications were unaffected by the diet. The largest decline was for the clobazam, up to one third drop in the level of the clobazam was noted. And there seems to be a correlation between the degree of ketosis and the degree of reduction of the ANT serum levels. So it is not presumed to be an absorption problem from the gut. It is presumed to be due to the metabolism in the body. If you look at the mechanism of ketosis affecting the function, ketosis affects several different metabolic pathways. So I'm not surprised that it is affecting some of our usual culprits in the first generation medications. Briefly about pharmacodynamic interactions. When you talk about pharmacodynamic interactions, I'm talking about synergism for side effects. You know, patients have signs and symptoms of toxicity, but their serum levels are in the normal range. And that often happens when you use a combination of GABAergic drugs. 2 or more GABAergic drugs produces sedation. Individual drug levels may be normal, but they may be a cumulative side effect. Ataxia, nystagmus, dizziness in the patients that are multiple sodium channel blockers. I've had patients who came to me taking oxcarbazepine, lamotrigine, and lacosamide, you know, all the sodium channel blockers. Patients are dizzy all the time, so you may have to proactively reduce these medicines. And tremor with a combination of valproate and lamotrigine. The levels themselves may be normal, but they could have accumulative side effects related to that. This is a beautiful cartoon that illustrates different mechanism actions of medication. This is on the excitatory pathway on the right side and inhibitory pathway on the left side. So when you are choosing medications, you often try to avoid medicines with similar mechanism of action. You don't want to be putting patients on levetiracetam and brivaracetam on the same patient. I would definitely avoid topiramate and zonisamate for the same patient. The same way, 2 sodium channel blockers. Sometimes I do 2 sodium channel, but definitely not 3. Okay, avoid those things. Try to mix when you're adding another medication. Always try with a different mechanism of action that is effective for the seizure type. So, last summarizing slides here. Some key takeaways. The drug interactions are frequent when you use first generation medications. Invariably, enzyme induction happens with many of the first generation medications. Valproate is prone for enzyme inhibition related drug interactions. So when the patients are on polytherapy, you need to be very careful about these things with first generation medications. As I highlighted, enzyme induction and de-induction is delayed by 1 to 3 weeks. So you need to be looking for these drug interactions. On the contrary, enzyme inhibitions are often more acute and dramatic because they lead to increase in levels of medicines and lead to toxicity symptoms. And many newer anti-seizure medications medications have unique drug interactions due to inhibitory mechanisms. Okay, you need to be aware of hidden drug interactions. For example, we talked about carbamazepine epoxide. So patient have carbamazepine-related toxicity, but if you check their carbamazepine levels, they are normal. So there's a hidden drug interaction. The same thing with free drug levels. If it is a protein binding interaction, if you don't check the free levels, it may be unrecognized. I view them as hidden drug interactions. And enzyme inducers affect drugs used for other indications. So the patients with multiple medical issues, especially in older patients and elderly individuals, be aware of what medicine you're using, alert their physician about what you're using, discontinuing, especially with enzyme inducer medications. And it's very important to able to give some broad guidelines and advice about birth control medications for your patients. So these are the most, I have shown many references here and there during my presentation. I found the first two references being very illuminative about the interactions, mechanisms, pharmacokinetics of different drug interactions. And these couple of articles by Dr. Peruka again highlights the several clinically relevant drug interactions. And the last one is for women with epilepsy and birth control related drug interactions. And several ones that is there already listed throughout the presentation here. I'm going to stop here and take any questions if there are any. I believe we have some time. Okay.
So Dr. Javasi from the UK asked, there's a previous report of CBC toxicity after the introduction of levetiracetam that was not associated to increase carbamazepine epoxide and suggested to be a pharmacodynamic. Is there any more insight about this interaction between carbamazepine toxicity and introduction of levetiracetam?
In my review reading, I did not come across this, but I understand that brivaracetam and levetiracetam have probably has some similar things. But in the brivaracetam, it's the epoxide hydrolase that increases the carbamazepine metabolite. I do not. I do not recall. I don't have any more insight about that drug interaction. It's probably less frequent and less talked about, I believe.
Okay, regarding this autoimmune encephalitis treatment that we use to treat with steroids and azathioprine and other medications, do you think we need to have in mind any important interaction between the treatment of autoimmune encephalitis and anti-seizure medications?
That's a great question. There are interactions between steroids and enzyme inducers can reduce the steroid levels. Generally, we don't use the steroid levels, in our practice. But definitely certain anti-immunosuppressive agents like tacrolimus, we use it for Rasmussen encephalitis, that can be significantly affected by enzyme inducers. Some of the biologicals, like for example, IL-6 inhibitor, tocilizumab, they have inhibitory, they interact with other medications. I'm not aware of anti-seizure medications affecting those medications, but the IL-6 pathway has some downstream effects on the enzyme, hepatic enzyme pathways, and alter the metabolism of several different medications. So it is the other way around with tocilizumab. Other than that, IVIG, there is nothing I came across. What else? In any case, if you are an enzyme induction, if there is another important drug you are using, it's always a good idea to check your clinical pharmacologist and look for any drug interactions before you proceed. So I would caution, because many of the drug interactions, you cannot memorize all the drug interactions. So if you're using any unique drug, important drug, there is an enzyme inducer on board, always check with that.
Okay. There are two questions regarding drug levels. The first one is, do you think it's really necessary to measure drug levels before introducing any new anti-seizure medications. And the other one is related to when to ask for levels in patients who are under anti-seizure medication treatment.
So in my practice, the time we use drug levels are more for efficacy and compliance. For example, in acute care situation, the patient comes to the hospital, you treat with phosphatidylcholine load. We often check the levels 2 hours later. And in a patient who is a critically sick, ill, we will continue to check the drug levels for management purposes. In an outpatient practice, patients have difficult to control epilepsy. I often check the drug levels to make sure that I'm trying enough doses and the patient is taking enough medications. So if I have a compliance issue, I may check the levels during their office visit. But if it is not due to a compliance issue, I just want to check the levels, I may check a trough level. I do not routinely check for every patient. If the patient is well controlled, 2 seizures, you start medicine seizure free, I do not have any concerns about compliance. I do not always check those levels. Sometimes in a difficult to control patient, you had a good control, and sometimes I would like to know what is the level that is controlling, so that in case if the patient has a breakthrough seizures, I may be able to see what is the level, and was it lower, is it because of the compliance issues? So it is difficult to give a broad answer for that, but in case by case basis, so drug levels can be really, really useful. In the ICU setting, if you're using enzyme inducers, you may not be aware of what's going on unless you check the levels. Okay? We had a patient with a super refractory status on phenobarbital and phenytoin and pentobarbital, and the patient was also on topiramate, clobazam, lacosamide in very good doses, but the levels were essentially non-detectable kind of thing. Unless you do that, you never know. So we had to either adjust the dose or move away from the medications and use medicines that is not affected by them. So that's the importance of checking the levels. And for toxicity, obviously, if a patient is clinically toxic, we often, at least in our practice, we often check the level and confirm that this is toxic and do it. Again, multiple polytherapy with enzyme inducers. If you're anticipating drug interactions, it's a good idea to check the level. Otherwise, you would never know.
Okay. Yeah.
The patient is doing well, you don't have to do anything. If the patient is not doing well, you have to do those things.
Definitely. What's your practice regarding levels in pregnancy? Do you request levels in young females in your clinic to have a baseline and then during pregnancy?
In my practice, whenever the patient is pregnant, we send them to an adult epileptologist practice. Okay. I believe that there are some specific guidelines about this. In particular about lamotrigine, I think many of our adult colleagues practice monthly check-in levels and adjust the dose for those patients. For other medications, it's probably less important. As we talked about, the estrogen during pregnancy induces the metabolism of lamotrigine and reduces the levels. Again, it doesn't happen with everybody. I think there are differences in the metabolic pathways. Not all patients with the pregnancy have a plummeting lamotrigine level. There are patients who do not have this issue at all. So without doing the level, you cannot keep increasing the dose. So monthly levels for lamotrigine, all the others may be a case-by-case basis. I'm not aware of active management with the other medicines.
Yeah. There's a question regarding the side effects of levetiracetam on behavior and depression in oncologic patients. Do you think that it's feasible for us to use lacosamide in those patients instead of levetiracetam in terms of these side effects and the interaction between antineoplasm medication?
So lacosamide does not have any major interaction. It is also metabolized by 2C19 pathway. It is prone for being affected by other medication, but lacosamide, to my knowledge, doesn't affect the anti-neoplastic agents. It should be okay. But again, if you are going to use some 2 odd drugs, check the literature. Don't go by one review article. Try to find out what's the most recent information. It's always a good idea, good practice in those situations, especially high stakes situations, right?
Okay. What's your opinion about interactions between new oral anticoagulants and levetiracetam or bevaracetam?
Newer anticoagulants. Some of them are prone for CYP3A4 enzyme induction, but not with the levetiracetam, bevaracetam. They do not have any CYP3A4. I'm not aware of the interaction with levetiracetam and oral anticoagulants. But CYP3A4 inhibitors, this apixaban and those 3 or 4 different medicines, they, except one of them, all the other 3 of them are 3 CYP3A4 inhibitors prone. So you could have interactions with that, but not to my knowledge about levetiracetam and bevaracetam.
Okay. So we don't have any more questions, Professor Naduvil. We are extremely grateful for you accepting this invitation. It was an honor to have you on board.
Okay, thank you. Thank you very much. I enjoyed preparing for the session. And again, you cannot memorize all these drug interactions. So if you're not sure about it, always check the literature for the most updated information. That's what. But it's always a good idea to have some ready hand references for at least the previously established drug interaction, older medications. And that's where those references could be helpful. Okay, good luck. Thank you for having me.
Okay, bye-bye.